morning, everyone. Thanks for coming to the AABD. And of course, that stands for Americans Against Bad Dentistry. Welcome to California. California is Latin for the word, how much can we take from the government? Anyway, welcome to California, beautiful Monterey. Nice to see all our old faces and friends that always come, and this has become like a ritual every year, but a great ritual. And for those new people that are here, I hope that we bend your paradigms a little bit. I'm sure we will by the time the weekend is over with. We have a great schedule for you. Just a couple simple announcements first. The Sonam people will be presenting lunch this afternoon, and that good-looking gentleman back there with the gray hair, the colonel, has tickets for lunch to stop by his booth. He's got a booth in the back, and just if you were interested in going for a free lunch on them, they'll give you tickets, all right? Today is Friday, and tonight is our wine and cheese party, right? We usually have it on Saturday. Yes, Colonel? Dietrich will be speaking during lunch, too, so I invite you to take part in that. He always has good things to say. And then tonight is our wine and cheese party, which will start maybe half an hour after the lecture. And that's where we all let our liver do push-ups. So I'm going to start, and I'm going to have Ed make the opening introduction and announcements. And I'm going to bring him up here.
Can you hear it?
Can you hear him, Chris?
Mike, is that okay? Gonna have to do. Can you hear it? No.
That's just for the video.
Eddie, here.
Oh.
Use this. I'll get your cane. Use the microphone.
You can hear that now. That has heavy breathing. First, I'd like to welcome all of you to the meeting, and I hope you can take back something that will be useful for you or fit into your legal defense, one or the other. The attorneys didn't come today. They're, I guess, celebrating their victory with Terry Lee. Is Terry here?
And they said that they offered their apologies, but they couldn't be here.
I know, but that's okay. They're on our team.
Is that the dental board, Terry?
No, these are the Beltway legal group. It's Charlie Brown. What are their names, Carol?
Jim Turner, Charlie Brown.
Jim Turner, that's right.
I know them by heart.
And well, they helped Terry get off with a 5-month suspension or 5-month probation, pardon me.
5-year.
5-year? That's nothing. In that 5 years, you can do anything you want, because by the time they gather up their forces and come after you, it'll be all over with. So you can do that. Anyway, I'd like to thank all of you for coming and participating in this seminar. This is a continuation, basically, of where we left off last time. We had the focal infection discussion. It's amazing that fungal infection is not part of our education, nor is the teaching of the pathology of focal inflammation. We don't get to look at it very much. And it was amazing to me to see these books that A.L. Shackman has written about focal infection and root canals and fraud. There was a big lapse in my education, and that wasn't about root canals, because I figured it out. I watched what they did, and you say, how in the hell can they do that? They're blocking out the tubules on the side opposite of where they should be. They should get all the remaining tubules out of there, but they don't even address them. They just skip by it, and they do a cursory, kind of a cosmetic root canal to satisfy their aesthetic senses. I wouldn't worry too much about anything. We have an eternity to get it right. I hope it may take that long. There's a quotation that I'm going to talk about, not now, but sometime this weekend, from Martin Fisher, talking about dentists being prepared and doing the right thing, and he asked if they had enough fortitude, basically, to get in there and do the right thing. And I think dentists do have that, but dentists are going to need to be trained better, especially in surgery. It's a very important area that has been relegated to mediocre cosmeticians. And that's, if you look at dentistry and all the societies that they have, the main society that has the biggest number of attendees at their meetings is the aesthetic group of dentists. Not the bondodontists, but because that's a very good method. In fact, we should be taking in and honing those tools that they use as aestheticians. If we use bonded composites, we can glue them on the enamel parts of the tooth that remain, and we should always try to save as much tooth structure as possible. We now have the ability to do this, whereas we didn't have that, say, 10 years ago, or even 5 years ago. Let's have each and every one of you look at dentistry as it approaches you and decide what you want to do to contribute and to help. You can pick any particular place you want to start and just go from there. And don't be afraid of the board. They're actually there to help you. So's the IR.
The insurance companies will pay all your expenses.
And so's the IRS, right? But I figured out, you get all concerned when they're after you. And they're making their leads in changing dates and having you jump through hoops and all kinds of things like that. That, of course, is very discerning, to say the least. you have these people in California. The president of the board and the state board members are allowed to carry guns, and they are allowed to carry guns. And the Georgetta Coleman was interviewed by an attorney for I'm just trying to think of the name of the. It's not legal defense fund. It's an attorney for these people. Anyway, she was being questioned by one of their attorneys, and they had some photographs of her, and she was carrying a gun, and they asked her if why she did that. She said, "Well, because dentists have criminal tendencies." There was no dentist up there defending our position or talking about it. But if I had gone before the board, you certainly would know about that, because I was going to issue a special invitation to all the legislators to come down and take part in this. I think that's about it, Chris.
Christmas has come early. Dr. Harada has a present for you here.
Okay, great.
Go on.
I have to.
Here, stay.
I'd like
Wait,
to
wait.
present to Ed a little special token of appreciation to Ed and the Academy members and whatnot. There's a little pillow that says, "To teach is to touch a life forever." And the Academy began in 1986, and many of us here, if it hadn't been for this Academy, we would not have been able to get the knowledge and help the numbers and countless people that were suffering that came to us. And each of us has paid our prices in our own ways, but if we look back at it, there's nothing more valuable than to have someone teach us. From all over the world, we had teachers come, and through Ed's, Carol, Norma's efforts, and all the members of the Academy, brought together all of you here today to share in the teaching. And once you learn, your life has been touched forever. And I want to give Ed an applause for his work in helping to touch our lives through the Academy's work. Thank you, Ed.
Why don't you stick that back in? You want to say any more?
No. I don't.
Ed's packing a gun, by the way.
You say the board have criminal intentions?
Well, where's the microphone? Works.
Right here.
No, but the board should equalize their influence. If they've got 10 big guys packing guns, we should have 10. And if they got 50 caliber machine guns, we should have the same. By law, you know.
By Constitution.
That's what equality is all about. Is the diameter of your gun barrel. Don't laugh. These are serious things. But we'd like to see each and every one of you finish out your career exactly like you wanted it to be, and not cooling your heels. We have one member or one person that's going to try to get his license back. So if that occurs and that happens, it's going to be a tremendous change for organized dentistry. They're going to have to start being nice to people like the IRS did.
Yeah.
Or they're going to get get their tits in a ringer.
Amen.
Thank you. Enjoy your meeting.
Got it? Before I introduce our next guest, Dr. Meinig, I think for 2 years now, I've always tried to open up the meeting with a little bit of a prayer. I think we should just take a silent moment to remember the people who have passed on, who have helped us. Dr. Issel's passed on. His wife is here today. Terry Allender, who was a friend of ours and was at our seminars. Anybody else that you can think of that has passed on and doing their work. We thank God for helping Terry here, for letting the Arizona boards crucify you and anybody else that's being persecuted, and our brethren out there from different states the boards are after, whatever. Just take a silent moment of prayer to bless them and bless the health of all of us, in particular Dr. Arana, and restore his health back. And please, Lord, take care of us because we're all under stress in this positions that we're in. Yes, sir.
I remember the name. Civil Liberties Union. That's not an ad or a plug. But they were there making them squirm. They didn't take their guns away.
I'd like to introduce our next guest, our first guest speaker, probably a gentleman that doesn't need an introduction. This gentleman fed me for a year, sending me an incredible highway of the sickest patients I could ever imagine. He's the author of the book, Root Canal Cover-Up. He graduated from dental school in 1937. I wasn't even a glint in my father's eye at that time. He was president, and correct me if I'm wrong, George, of the American Endodontic Society at that time. Is that what it was?
I was never president. I was one of the 19 that started
One of the founding members, right? So, I'm sure most of you, if not all of you, have read his book, Root Canal Cover-Ups. I give it to my patients in the office if they have any questions about the work we're about to undergo in our office. I'm very familiar with this man and his wife. We met when I was in Santa Fe. I did some surgery on his family, and they all seem to do okay. They're all still alive anyway. And without further ado, I'd like to introduce Dr. George Meinig. Let's give him a big hand.
Hey, if I'm too close or too far from the microphone, the signal or
Do you have slides, or
Pardon?
do you have slides?
Yeah, I've got slides, yeah. Yeah, I got a lot of them.
All right. Say a couple words. Testing, 1, 2, 3, 4.
Testing, testing, 1, 2, 3, 4. Am I too close or too far?
No, you're okay. You're all right.
All right, just like that? Thank you.
Do we have a laser pointer, Carol? Marcus?
I brought one.
Do you have one?
Let me see if it works, yes. I can't, I'm a little stuffed up about telling you how thrilled I am to be with all the greats that are here today. This whole thing has meant so much to me. Thank you. Slides now. I've got way too much here to talk about today, and I don't know, Chris, you're going to have to cut me off when you have to.
You have a lot of time. Just do your thing.
So the problem is that we started all of this, or I became acquainted with Price's root canal work in January of 1993. Now, actually, I became acquainted with his nutrition work years and excuse me.
Pointer, and here's your clicker. Okay.
Yeah, years and years ago, I became acquainted with him for his nutrition work, and I became a member of the Price Pottinger Nutrition Foundation. Was on a board member for many years, and I learned about all of his research with dental materials and dental problems. But I never knew a thing about his root canal research until January of 1993. And at that time, Pat Conley had learned about the fact that it existed. Nobody in the board had ever knew about the root canal work. And the reason was that the 2 huge volumes in which he documented the work were buried on a shelf way down in the corner of the storage room that has all of his research memorabilia, and nobody saw them. Well, when those 2 came to light, Pat Conley, our executive secretary, knew about my background in root canal therapy, and I think most of you have a paper out there about my background, so it's important that you kind of know where I'm coming from in this thing. At any rate, she called me and told me about it, and I said, well, you better send the books so I can see. And she says, yeah, you better make a report to our board of directors as to whether this root canal stuff that he's written about is still viable or not. And so she sent them, and of course, once I got them, I couldn't put them down. I was up till 3 or 4 every morning reading them, because there's 1,134 pages in the 2 volumes that he documented this work. At any rate, I'm introducing to you Dr. Price here, Dr. Weston A. Price, and he was a sheer genius. For those of you who know anything about his background, know that from the time he graduated dental school until he passed on, he spent half of his time practicing dentistry and the other half doing dental research. Now, that research covered all kinds of different things in dentistry, and it happened in the early part of the 1900s, and so many of the things were brand new at that time, and he was the bulwark of some of the new things that happened during that period. But along the way, he got acquainted with Frank Billings and with Rosenau and the focal infection theory, so that entered into a lot of what he was doing. Well, revolutions start with one person, and he started one heck of a revolution. He really didn't start it. Frank Billings started it, but he contributed a great amount because he did the dental end of things, and we're going to talk about that right now. These are the 2 huge volumes. They don't look as huge on this table as I thought that they would, but they do contain 1,174 pages, and they're chock full of pictures, and they still are available from the Price Pottinger Foundation. It's not the book's out of print, but to reprint it would be a very costly affair, and so they can have it copied, and the copies now with computerizing the pictures are as excellent as the originals. They're rather expensive because you have a lot of pages to copy, but anybody that wants to follow up and hear it right straight from the horse's mouth, you can get these 2 books. Wrong place. Now, Price was not only revered by the dental profession, he probably had as many or more followers in the medical profession as he did in the dental profession. And I just show this to let you know that he was highly thought of in his time. Here at this particular dental meeting, he was given recognition for, I don't know, 15 or 20 items there of things that he had done to help society and to help the dental profession, and that was signed by 26 past presidents of the American Dental Association. Now, for you dentists out there, don't be alarmed. I'm going to take you back to freshman dental school and show you something about the anatomy of tooth. And many of you in this room, of course, know what I'm going to be talking about, but some of you don't. And don't be alarmed, because if you don't know what this anatomy is, you're not going to be able to understand focal infection and what has been happening to the people in our country. And here we see the enamel of the tooth, which those of you who are not dentists, of course, know about, but that's what it looks like. And it's a hard calcium substance. Coming along the root of the tooth, covering the root of the tooth, is a cementum. That is also a hard calcium substance, not quite as hard as enamel, but it's extremely hard. And attached to it is the pericemental membrane, which you see here. That's a hard fibrous tissue that has fibers running from the cementum of the root of the tooth to the bony socket, and it is those fibers and the pericemental membrane that keeps the tooth from falling out. And so it's very important for other reasons, however. It has an excellent blood supply, and it has a lot of properties which help keep teeth alive and healthy. And we'll learn more about that as we go along. In the center of the tooth runs the root canal. And up in the crown of the tooth, there's usually a little chamber, which is called the pulp chamber. And that, everybody knows that that root canal contains a nerve. Some people who are non-professionals don't know that it also contains an artery and a vein and other tissues as well. And those root canals have accessory canals coming off in various areas of the root of the tooth. And they also contain an artery, nerve, and vein, and they help supply the tooth. Now, all of the rest of this tooth that you see here is dentin, and that dentin is a very important part of this whole process that we're faced with. And the reason is that everybody knows that it's quite hard when your dentist drills on your tooth to prepare a cavity or a crown. You know, you can't tell where the drill is, but it sounds like he's cutting hard stone. Well, the interesting part about it is this dentin is it's not quite as hard as enamel, but it is a very hard, but it is not a solid material like stone. It's composed of little tiny tubules. Those tubules are roughly 1.5 microns in size. And they tend to be a little larger up in the crown of the tooth and tend to get smaller as you get down to the end of the root of the tooth. But this is a very important part of this whole situation. If we took the smallest front tooth that you have, which would be relatively about a half of this molar tooth, and we took that tooth and took the dentin tubules out of it and attached them end to end, each one, they would extend out for a distance of 3 miles. Now, that seems pretty imperceivable in any case of the word, but the importance of that is that those tubules in normal life contain a fluid, and that fluid contains nutriments, and it's those nutriments that keep teeth alive and healthy. Now, when that artery comes into this tooth, the dentin tubules, which open up into that root canal, receive nutriments day and night all of the time from that artery, just the same as the arteries drop off nutriments to every cell of the body. They're dropping off nutriments to those dentin tubules. Now, and those dentin tubules are going to all parts of the body. Even up here in the crown, we know they now get into the enamel of the tooth as well. Now, the important part of all of that is that that's what keeps teeth alive and healthy, and we're going to get into next what really happens here. Oh, this is Dr. Ralph Steinman. He's a professor emeritus now at Loma University Dental School, and he did a lot of this research on dentin tubules and the fluid in them. Frankly, we didn't even learn about dentin tubules when I was a dental student, because you know that was a long time ago. But it wasn't too long after that I learned about dentin tubules. But I didn't learn about this fluid and everything else until more recent years, and a lot of it came out of Dr. Steinman. He wasn't the only one that did this, but many of them did. Here we have the caries picture going along in various stages. The important part here is that once that caries gets into the enamel of the tooth, the bacteria that are involved in the cause of the caries action also get into those dentin tubules. Now, dentist prepares his tooth, he cuts away the cavity and a little of the good tooth, and we think that that pretty much handles the situation. But really, there's got to be some more research with electron microscopes because when you get a deeper cavity, we have to wonder is how far have those dentin tubules gone? Have they really gotten into the pulp of the tooth here, even though the decay hasn't gotten into the pulp of the tooth? And nobody's quite come up with an answer to that, to my knowledge. And of course, when you have the decay actually into the pulp of the tooth, there isn't any question then the bacteria that are involved here are traveling down this root canal, and they kill off the artery, vein, and nerve that's in that tooth, and it decays away and it becomes full of pus and gas, and eventually you get a granuloma or a cyst at the end of the root of the tooth from that infection. Well, there's a big problem with all of this because let me show you this picture. This was the best microscope that Price could have at the time he was doing this research. And this shows low-powered reading of the bacteria in the getting into the dentin of the tooth. But here under high power, you see a dentin tubule. And in the little black dots, if you can make them out here, are the bacteria that appear in those tubules. Now, I saw this picture. These came from those two books that I pointed out at the beginning of this talk. And I saw this picture in that book. It was the first time that I had ever heard that bacteria existed in the dentin tubules. And I was in utter shock about that because all of a sudden that meant something a lot more important than anything I had ever heard before. And I've given quite a few talks to medical and dental groups around the country. And one of the interesting things is when I'm talking to a dental group and I bring up this picture, I get dead silence. To me, that indicates that none of them have ever heard of this before either. Now, I heard about it excuse me, in January of 1993, and this is a little less than 6 years later, or 5 years later, it was last year, and they have not heard of it either. And you got to keep in mind that the average dentist in the country, even today, does not know about this. It's not that they're ignorant, they just haven't read the research, and they haven't seen enough of it. Some of them have read some of Price's stuff, but not very many have gone to the point of seeing this part of the data. And so we have to recognize how important that was to the scheme of things. Now here we have an electron microscope picture. This is enlarged 1,200 times, and you see the dentin tubules cut in cross section. And here you see where there was a break here, see them longitudinally, and you see that they do not run uniformly like the average picture of a tooth shows them to do. They intermingle with one another, and it's that intermingling with one another that gives dentin that density and the hardness so that it's almost as hard as the enamel of the tooth. And here we see enlarged 5,000 times. This is a tubule. And this stuff that's in the center there, labeled B, are the bacteria in the tubules. So you see that they actually exist. Now you can keep in mind, if you've got 3 miles of tubules in your smallest front tooth, how many billions of bacteria that can exist all at one time. And all of these bacteria are pouring into your bloodstream over the night and day, every day that exists. Here I took a drawing of a tooth and I did a root canal on the one side and I left the other side so you could see both things at the same time. Excuse me. The reason I'm showing this is that when the dentist finds that there's infection here, he goes in with fine instruments and he removes the infected tissue, what remains of the nerves and the blood vessels and so on. Sometimes there's nothing but pus and that sort of thing, but sometimes there's still a fair amount of tissue left in there, and he removes all of that. If that canal is pretty small, he can't get enough irrigating solution in or disinfectant to kill the bacteria, so he enlarges that root canal with small files and reamers until it is of a size that he can work with it. And then he floods this with irrigating solutions and sucks that out, and then he puts in disinfectant to kill the bacteria that are in here. And when he thinks he's done that, he does a root canal filling, which is represented by the whiteness of that material, because that's the way it looks on an X-ray after you've been it's been filled. There has never been a root canal filling yet to this day that doesn't shrink some a week or two along the way after the tooth has been filled. Now, when dentists do this now, they fill those quite well, and it's densely filled. Years ago, we saw many of them that were done very carelessly, but today, most of them are done exceedingly well. But you got to keep in mind that that stuff shrinks a little bit, and even though it's hundredths of an inch, those little air pockets get full of bacteria coming from those dentin tubules. And so you get a new infection in that root canal, and he doesn't know that. The endodontist doesn't know that at all because he's never seen the research. Now, but the dentist says, well, so what difference does it make? You put this root canal filling in, and now these bacteria are going to die in those tubules because there's no air anymore to sustain them. Well, Price thought most of them initially were aerobic and needed air to exist, but he found the aerobic ones changed into anaerobic ones. And we now know actually most of the bacteria that are present anyway are anaerobic to begin with. And so, meaning that they don't need air to exist. So the dentist is pretty wrong when he says they're going to die because they just don't die. And then he turns around, and when you get him with that one, he says, well, so what? They're trapped there in the tooth. They can't get through the dentin. The cementum here, or the root, because that's such a hard material, you couldn't get bacteria through that no matter what. Well, what he doesn't know is that Price did some exhaustive research on that. He put some steel tubes in healthy teeth and pumped water into the root canal under pressure, and he put a little blue dye in it, and lo and behold, that water and blue dye came right through the cementum. And then Price knew that it was a semi-permeable membrane. In other words, it would pass fluid. Well, it's too dense to pass bacteria, but it's not too dense to pass the toxins of the bacteria. And so Price did some studies of that, in which he showed that he separated the toxins and the bacteria. He injected bacteria in one group of animals and toxins in another group, and lo and behold, the animals that got the toxins got sick sooner and died quicker than those that got the bacteria. So it was a very interesting study. But at any rate, so the endodontist doesn't know that this stuff is getting out. And what gets out of the bacteria is any bacteria near a lateral canal, like here, and those dentin tubules will get out of that, through that lateral canal, and come into the paracemental membrane here. And once it gets in there, that's got a good blood supply, it infects that whole periodontal membrane. So once it's in there, of course, it's the blood supply going from that into the surrounding alveolar bone, it gets into that. And now it metastasizes just the same as cancer cells metastasize, and travels all around the body until such a time as those bacteria find a gland, organ, or tissue that they think would make a good summer home or winter home, and they settle down and set up a whole new infection, which is, of course, what focal infections are all about. And so this is the story about what's happening here, and all of you have to picture that in order to really understand the process that's going on here. Well, it all starts with a tiny cavity. Now, the tiny cavity doesn't do it, but the problem is that most dentists don't get the tiny cavity filled because they don't go frequently enough, or the dentist doesn't tell them about it or something. And by the time it gets deep enough, they need a root canal, or they need the tooth extracted, and that's why it all starts pretty early in time. Most of you know that X-rays don't show everything, but most people are overpowered by the function of X-rays. And you can have a granuloma or cyst. Usually they occur at the end of the root of the tooth, but sometimes they come off of those lateral canals like you're seeing here. Now actually, this tooth is this tooth. This is the front tooth, and this was in the back of the front tooth right here. And I had a dentist tell me removing one the other day that was a huge way in the back of the tooth. Well, anyway, Price took that tooth after he took it out, and the granuloma was still there, so he turned it sideways so you could see what it looked like. Now, a lot of times you don't even get a granuloma in the beginning of these infections, yet you got a badly infected root canal here. Well, those bacteria are getting out the end of this root of the tooth and getting into the circulation of the jawbone, so you've got a problem with that, because you can have this tooth without showing anything here on it at all, and it's still pouring bacteria into your system night and day all of the time. And so you got to know that you could have these for a long time without it ever being apparent. Every good research program usually has one program that sets off the theme for everything else. And with Dr. Price, it was arthritis. And the reason was that he had done a root canal early on for this woman, and she developed a very severe arthritic condition. And when he learned about, from Rosenau and Billings about focal infection, he said, gosh, it looks like maybe that root canal I did for her is the cause of this problem. And yet she had no symptoms in the tooth. It looked perfectly fine on x-ray. And he started to say to her, hey, you know, you better let me take this tooth out. He said, I'd like to do some experimenting with this and see if we can find out why you have this arthritis. And of course, like most people with root canals, they say, no, I don't want to have that tooth out. You know, it's fine. It doesn't bother me. And so she postponed for a while, but finally she consented, and he had her in one morning and removed that tooth aseptically. And aseptically because so many bacteria in the mouth, if he didn't do it aseptically, the dental profession would say, well, the things that you're finding are because you contaminated the tooth with the bacteria in the mouth when you took the tooth out. Well, that's a common criticism even to this day of Price's work, but we're going to show you something to show where that doesn't hold water. But that'll come in a moment. At any rate, what he did is he took this root canal filled tooth out of this arthritic patient, and he had secured a laboratory animal. In this case, it was a rabbit. He made a small buttonhole incision in the back of the skin of the rabbit, and he tucked that extracted root canal filled tooth in there, and he put in about 3 or 4 sutures into the area to keep the tooth from falling out. And he returned the animal to its spacious cage, which had first I should tell you about the woman, and this is her hands. You see how bad she was. Her ankles and her knees were as bad. These 2 pictures were taken after she had the tooth removed and she was beginning to recover. She spent most of her time in bed because she couldn't get around, and she needed somebody to push the wheelchair because with those hands she couldn't handle it herself. And here she was being able to now use crutches again, which she hadn't been able to use. But at any rate, this rabbit that had the tooth under its skin was put in a spacious cage that had plenty of good food and water, and they awaited developments, and it didn't take long. In just 2 days' time, that rabbit had the same arthritis in its limbs, and you can see that very clearly here, that the patient had in hers. It looked almost identical when you saw it between the 2 of them. And the rabbit passed away in 10 days because of the infection that came from that tooth. Now, Dr. Price was an expert at taking health histories, and he did elaborate health histories for every patient. And he said to himself, gee, I got people with heart trouble, kidney trouble, and liver trouble, and all kinds of degenerative diseases, and a lot of them got root canals or infected teeth in their mouth. Do you suppose that those things are coming from those teeth? And so he started to advise those people to have the tooth out, and he would do that and have them in, and then he would implant the tooth under the skin of an animal. And he used, incidentally, all kinds of different animals in these studies. He used rabbits most of the time because they were smaller and they were easier to handle on a laboratory basis for a large number of cases. But he used rats and monkeys and dogs and all kinds of animals. And it didn't matter what kind of animal, the same things happened regardless of which ones. At any rate, he has a patient with heart disease, and he implants the root canal filled tooth under the skin of an animal, and lo and behold, the animal gets heart disease. If you had kidney trouble, the animal would get kidney trouble. If it was joint problem, it was joint problem. If it was eyes, it was eyes. And it wasn't 100% that way, but it was in a high percentage of cases. And incidentally, Billings and Rosenau found the same thing, but they were doing from cultures of the bacteria rather than directly from the animals. Now I'm going to show you a few of these cases that Price did. The second book is full of case history records similar to this, but I've put a few of them here. This woman had a heart condition, and she had 2 central incisors that had root canals. And I apologize for the picture, but I had to make this slide from the book, and my camera apparently wasn't efficient enough to do that well. And so you can't see it. You'll have to take my word, but this was a perfect root canal filling right to the end of the root of the tooth on both teeth. Both of them had root canals. With absolutely no sign of breakdown of bone here at the end of the root of the tooth. They looked extremely healthy. The woman had no problems with those teeth. They showed nothing on x-ray. She had no symptoms of any kind. And she did have a heart condition, however, and so Dr. Price said, we better remove those 2 teeth and see what's going on here. And when these were implanted under the skin of an animal, both teeth developed endocarditis hearts. And this is what you're seeing in the 2 different animals, is the endocarditis heart. Here we see 2 different patients who had bladder infections. This one, the root canal filled tooth causes extreme swelling in the animal, the bladder of the animal, and this one had a perforation of the bladder here. And here we have an ovarian cyst in an animal that came from a woman who had an ovarian cyst in her root canal filled tooth, and the rabbit caused this large ovarian cyst. Now Price said and found that women were particularly prone to infections of all kinds in all of their female organs, including the breasts, because of dental infections. Or it could be, instead of infection in that form, it could be in the form of a tumor or some kind of a growth as well. And so you women should be particularly concerned if you have any if you have any teeth that are dead or you have any cavitations, because you could be suffering from some of these problems. Now, focal infection is what this is all about. And when my book came out in June of 1993, it, for the first time, rediscovered the 70-year burial of the focal infection theory. Now, all of this information continued to be available in the literature, but once nobody was talking about focal infections, who was going to look in the literature to try and find it? And so, from all effects, everything about focal infection has been buried for almost 80 years now, really, but over 70 years. And so the appearance of my book at least has opened it up for people to start looking at what that research was all about. Here in Hubert Newman is a professor of periodontology at the Eastman Dental College in London, England. He wrote an article that appeared in the Journal of Dental Research in December of 1996 called Focal Infection. And it's a very good article. He had 137 or 47 references in it. I was utterly amazed at the number of references that he listed, because the Endo Association keeps saying there aren't many new things, and this was done in 96, so you know there was a lot of things that were recent. At any rate, it was a very good article, and we're beginning to see more and more of this sort of thing happening. The Three Musketeers. Frank Billings was one of the United States' most famous physicians in the early 1900s. And it only dawned on me a few weeks ago really how important it was when I heard that many times that he had completely reorganized medicine in the early 1900s. And I didn't understand exactly what that meant until a couple of weeks ago. It suddenly dawned on me in talking about what's happening in the 20th century, that he was talking about people that were dealing with the 1800s, and what he had done was to take medicine, the way it was practiced all through the 1800s, and put it into the 1900s. So he was well known medically because of that, because it made such a big stir. Incidentally, it's E.C. Rose now. I made a mistake on that, unfortunately, but it was too late to change it. Any rate, Billings, after he, thank you. I'm not going to accept that one. I'm not sure where it's from. I brought my own. I don't like all that chlorine stuff, so. Anyway, thank you, Chris. In 1904, Dr. Billings announced the focal infection theory, introduced it into the United States. Now, from then on, he did continual research on that subject, and by 1914, he had done sufficient research to be able to write and publish an article in which he stated 95% of all focal infections came from teeth and tonsils. Now, this was quite a stir. Now, where did the other 5% come from? They came from infected fingernails, appendices, sinuses. It could come from any infected tissue somewhere in the body, but this represented only 5% of all of the focal infections. The vast majority came from teeth, and secondly from tonsils. And a lot of times you got to get the teeth problem cleared up first, because a lot of times the tooth thing is draining into the tonsillar area, and you don't know which one the problem is. At any rate, he did probably at least 25 years of research. We don't know exactly how much. But now Dr. Rosenau, he started about 1905 doing research also on this subject of focal infections, and he ended up with almost 55 years of research on this subject. 30 of those years he spent with the Mayo Clinic as head of their experimental biological research at Mayo Clinic. And in that period of time, he wrote over 300 articles that appeared in the literature, and 40 of those appeared in the Journal of the American Medical Association. So you know that he was one of the most highly respected bacteriologists in the country. And his work and Billings' work have never been refuted. There's never been any peer review information of any stature to show that this was not, what they did was not true, and yet the Endodontic Association, I hate to tell you, still is claiming that that is true. And of course, Price covered the dental end of things, which I've been showing you about, and I got acquainted with that because I happen to know of Price. I didn't meet him personally, but know of him from previous times. Here we see one more case. This woman had this severe eye problem. It's not showing up very well on this slide, but severe inflammation in this eye. And for 2 months, the physician was not successful in curing the infection. And the patient happened to get into her dentist, and he said, "Hey, what's the trouble with the eye?" And she mentioned it was 2 months' time, and he said, "Hey, we better get some x-ray pictures." He was smart enough to know about focal infections. He says, if you got a bad tooth, that could be causing that. And lo and behold, she had a root-filled tooth here, cuspid, and another cuspid here with one, and here a bicuspid with one. So each one was implanted under the skin of a rabbit. That first rabbit was almost totally blind in 2 days, and this one was totally blind in 2 days, as was the third one. And so you can see what can happen to eyes. And I talked to a eye surgeon in Texas one day. Somebody told me he was running into a lot of these cases and were referring patients to dentists to remove teeth. And usually for dentists to get much from a specialist in time, if you get 3 to 5 minutes, it's pretty much. When he talked to me for 25 minutes. And he ended up saying, he says, "You know, I'm doing more dentistry than I am eye doctory." And here's the real important slide of all of them here. When Price first reported some of these problems with implanting teeth in the dental and medical journals, he had a number of dentists come to him and say, "Hey, you know, you take any extracted tooth and put it under the skin of an animal, chances are the animal's going to get sick and die." And Price said, "Well, I don't know that I can go along with that, but let's find out." You know, this is his type of attitude. And so he secured 100 healthy teeth. These were teeth that were taken out for orthodontic purposes, because of impactions. These were teeth without caries, without any known large infection around them. Each one of those teeth was implanted under the skin of an animal. And of course, he used all kinds of different animals. Otherwise, if he'd have just used rabbits, they'd have said, oh, well, it only applies to rabbits. It doesn't apply to anything else. And so I think you all know what happened. Nothing happened. Not a thing happened with these people, these animals that got these healthy teeth. They remained dormant under their skin for their entire length of life of the animal. So this proved that you had to have infection present in order to create the problem. And with 100 of them, it pretty much satisfied the problem. And occasionally you hear somebody that's complaining that he had no controls because they didn't know about this study. And yet it's been published and they should have known about it, but that happens. Once in a while, the animal would cause that tooth to be pushed out of the skin. Their immune system would be so good. Rats, for instance, have very good immune systems, and it happened very frequently with rats, so they could never use rats in the experiment because almost invariably in a couple of weeks the rat would have the tooth shoved out. We call it exfoliate, and that would be it. In just a few cases, the tooth would dissolve away because the immune system would cause it to break down and get rid of it. But most of them, a good many of them, developed a cystic sac around them. And so this would worry them a little because some cysts are infected and some cysts aren't infected. But Price was no slouch as a bacteriologist, and he had in his Dental Research Institute group a number of bacteriologists. And so they would go in after a period of time and open those up and do bacteriologic studies, and they found that they were always sterile. And so this is why that proved to be such a good research program. Root Canal Association. I don't think I have to explain that. They don't know what they don't know. This is unfortunately what's going on. Oh, I probably should say something because the endodontists are all really very dedicated people. They're imbued with wanting to save the teeth and to be able, people have teeth and to be able to chew properly and so on. The criticism of them cannot be made directly because they don't know this research. Unfortunately, it can be made at the original leaders of the root canal push because they knew about the focal infection thing and they kept declaring it was non-valid and that it was nothing to it and that what they were doing was more important. And really it was their position to really study it to find out whether it was important or not. But unfortunately, the average dentist, no matter how dedicated it is, doesn't know what is going on. And we have to face that fact, and it's a problem. Now we have, this broke loose about last year, periodontal pockets cause heart disease and heart attacks. Well, this was a real surprise because newspapers were giving this headlines. USA Today had almost a full page of coverage on this subject of periodontal disease and focal infection and how this was such a big problem. Now, they never talked about root canals in the same light, but we'll get to that one of these days. What's happening, of course, is this pocket that's occurring here. And once you have a calculus or tartar deposit on the root of this tooth, if you look closely, you can see the periodontal membrane following right along here. That little white line, it's the periodontal membrane. Now, once that tartar deposit accumulates there, the bacteria that accumulate in that gum pocket, they get into that periodontal membrane and start the infection going, which causes this bone to break down as well. And eventually you get this pocket in here, which is full of bacteria. And of course, this is where the bacteria getting into the bloodstream do the same thing as they do with a root canal filled tooth. And here we see a much more severe case. You can see this is almost clear to the end of the root of the teeth. You can take these teeth out with finger pressure because there's not so little bone left remaining holding them. And one of the things to know is that Price did blood studies for every patient, and they showed these various different changes. And he also did for every animal in which they implanted a tooth, they did a similar study so that they could compare the two and see how they compared. And most of the time they compared relatively in the same way. Now what Price found was that not any one of these things was ever really diagnostic of the tooth being infected, but every one of them either was higher or lower because of the infection that was present. And so I get people to telephone me all the time and say, what kind of a blood study can I have that'll tell me whether that tooth of mine is infected? And I will say, have you read my book? And they'll say, yes. And I said, well, you should have read there that every tooth that has got a root canal or infected, it is always infected, and it's never going to be any different because you can't get rid of those bacteria and those dentin tubules. And so I said, that's your diagnosis, not this. Now, this can tell you, that you have a lot of things going on that are different, but they can't tell you diagnostically what's going on. Now, one of the key things he did that was pretty diagnostic was ionic calcium. And we today have not done much with ionic calcium levels. We usually look at total calcium and phosphorus balances and that sort of thing. But Price did everything with ionic calcium. And he found that when the tooth was implanted under the skin of an animal, that animal usually would start out with the ionic calcium a little lower than normal, and that would keep getting lower and lower as the animal got sicker and sicker until the moment just before death, and the ionic calcium would become 0. Now, in a few cases, he found that it was a little higher when he first implanted the tooth, but it usually very rapidly came down and came to be less than normal. And so he found that ionic calcium was important that way, and he also found it was very important in a lot of other ways of things that are happening. And I would like to have enough time to tell you what happens in arthritis and a number of things with ionic calcium, but we got too much to talk about to cover too many of the things. We got to get on to the cavitation problem, and this goes by different names, and as you know, most people are now using Jerry Bacot's NICO name, neuralgia-inducing cavitational osteonecrosis. Well, that's enough to spin everybody's wheels with that name, but it says exactly what it is. It says it induces neuralgia, it induces cavitations, it induces osteonecrosis, which is dead bone. And so the name tells you exactly what the disease is. Let me show you a few of these because this is one that you want to be aware of. And many of you, of course, are doing these, and so you are aware of them. This is a third molar area, and this is a very large one here. It looks like two because this ridge of bone in the mandible makes this look like two areas, but this isn't two areas, it's one large area. And over here you see another view. This is the one for the first molar, and that's another form of the same thing. And here's a very large one here. My friend Michael LaMarche up in north of Seattle, this patient came in and had a history for 31 years ago. This tooth was removed, had histories of very severe headaches for all of those 31 years, plus a lot of degenerative disease problems. And he had that history all marked down, and he saw this on the x-ray, and he told her that there was a good chance that this had a lot to do with her problems. And so he removed this, and 2 weeks later she was without headaches, and most of the degenerative disease situation had disappeared. Here you see this is following the periodontal membrane, and what's happening, of course, in these cases is that the infection that's in that periodontal membrane usually doesn't go away. And we think in a few cases it might, but most cases it stays there, and eventually it starts to swell and get bigger and bigger and bigger, which is what you're seeing happening. The dentist here, because this looked pretty dense bone here, he said, nobody's going to believe me how deep this really was. And so he took a needle, and just with hand pressure, this was cancellous enough, he was able to push that needle right through that cancellous bone right down to its depth. And then he took another x-ray of it. And the reason he did that was so that the dentist wouldn't doubt the fact that, that he didn't drill a hole here to expose this situation. So Anyway, that's another form of the same thing. And you see on the other side, here's also cavitation here, and probably here. Now this is an edentulous upper, and when I first heard of these cases, I had remembered seeing a lot of these in practice of where we saw the periodontal membrane quite well outlined, and nobody had ever told us that this was infected, and so I looked at it as being a nutritional problem or calcium problem or some kind of a metabolic problem where they didn't have good bone growth in here. Well, of course, once I learned it was infection, I had a bunch of x-rays in my in my attic at home, and I went up in the attic. The third envelope I opened was this one. So I remembered accurately that we saw these very often. Well, this is the bicuspid tooth, and this person had been edentulous up above for a long time, and so the ridge had been receded here. This bone here used to be down here, but it receded, and now when you get in here, you see there's a periodontal membrane breakdown here and here. That was for a bicuspid, but then when you get into here, it's not showing too well on this film, but each one of those molars has got 3 roots, and so you got all those periodontal membranes breaking down. So this was entirely full of breakdown of periodontal membrane because of that situation. And if you do edentulous areas in your practice, you'll see lots of it. Now I'd like to introduce my wife, Eleanor, and she's here in the audience, so you can talk to her if you wish. I'd like to tell you more detail about this, but I'm not going to have time. But she has 7 cavitation areas, and this one is quite clear to see. This one is not quite as clear to see, but if you look closely, you see the lighter area of bone right here, and it actually extends up into here. This was exceedingly large. It completely surrounded the mandibular nerve. This root canal I did for her in 1970. It was beginning to show breakdown here at the end of the root of the tooth. And when that tooth came out, there was actually no soft tissue infected material here at the end. It looked like a pretty healthy tooth, but of course we knew there was bacteria in the tubules. You look closely, you see this area here. That's the cavitation. I took this first molar out for Eleanor in 1940, and she had had a toothache, a large amalgam in the tooth. She developed a very severe dry socket, and most of you who are doing these know that dry socket is almost a cinch that you're going to have a cavitation. 1 year later, I took an x-ray picture here, and it showed this area, just the way you see it here. And I hastened down to Chicago College of Dental Surgery, where I graduated, and saw Dr. Svoboda, head of the oral surgery department, and said, "Hey, Spud, what's this all about?" And he said, "Oh, don't worry about it. It's nothing. It's nothing." Well, I wasn't so sure it was nothing, but what could I do when the head of the oral surgery said it was nothing? And so every x-ray we ever had showed this area. It never went away. And then this little piece of amalgam was there. Well, she had a big amalgam in there. And in 1940, dentists didn't have vacuum systems to vacuum these areas out. We had to do this with mopping with gauze and that sort of thing, and I had missed that piece, but I was entirely embarrassed about it for years. And when Chris Husser got in to do this, the mandibular nerve here was completely surrounded, and he found that piece embedded into the sheath of the mandibular nerve. So what happened is it took him about 15, 20 minutes to tease that out of there so he wouldn't destroy the nerve itself. At any rate, I won't go into, I'd like to tell you all about the whole case, but there was a cavitation here. Didn't show anything here, but there was one there. We did that exploratory. This tooth, which looked fine, was dead. And this third molar, incidentally, was the only third molar she had. She didn't have the other 3. And yet they were all 4 wisdom tooth areas were infected. And you can see the infection occurring down here and at the end of the root of the tooth here. I think you can probably see the area there, and you may or may not be able to see it there. At any rate, those are the 7, and this has been quite an education. And it was also an education because I had 7 of them also. Don't comment. Nothing is more frightful than ignorance in action. Isn't it amazing how much ignorance we've had for this past 70 years? It's just mind-boggling. Tom Levy and Hal Huggins wrote this article that appeared in the Journal of the Advancement of Medicine, stating that routine dental extractions routinely produce, or should be said, cause cavitations. And this is, of course, what happens. They have recently written a new book, and they've just sent me a copy. I thought maybe you'd like to be aware of it, so I've made a copy, a film of it. Here's a skeleton showing cavitations of the long bones. You know, everybody probably knows that you can have these cavitations in your arms or legs. And when I first learned about them in the mouth, I said to a number of physicians and one orthopedic surgeon, are these the same things we're seeing in the mouth? And they said, no, this is ischemic osteonecrosis. Well, that means poor blood supply causing dead bone. And that's what you're seeing in these, where the black spots are. Well, actually, in the mouth, where most of them are coming from extracted teeth, we do see areas, and you have to keep in mind that the pressures of the teeth on these jawbone and transferred to jawbone are so great. At times, some people can get 200 pounds pressure, you know, on their teeth, and that can snuff off a small blood vessel. And if it does snuff off the small blood vessel, then the bone around that area will die because of lack of food, and now they will have a ischemia, in other words, a poor blood supply. And when you get a bacteremia going, then that dead tissue will become infected. And so that's another cause, even in the oral cavity, for these infections. So it's possible to have it even without it. This is me, and I won't go into it. There's 7 cavitation areas for all 4 wisdom teeth. They had been extracted over 40 years before. And down in here and in here and up here. All of them were infected, and we had, you know, biopsies on all of them. But here's the real one, and I don't like to be stealing Dr. Bacot's thunder with showing this, because this is his picture. But I think he'll have other things to say anyway, even if he re-shows it. And he may not, and I had to face the fact that he may not, and I wanted you to see it. So, of course, this is a large cavitation area. This man had trigeminal neuralgia, and he refused to have the surgery in his face to sever the nerves to cut down the transmission of the pain. And for those of you who don't know, trigeminal neuralgia is the worst pain known to man. And the textbooks say no known cause, no known treatment. And this man wrote a letter to Dr. Bacot, and he willed his skull to him, and then he turned around and committed suicide. He said to Dr. Bacot, please see if you can find out why I had this disease. Maybe you can help some other people to overcome it. And that's exactly what happened. Here you see these little dark brown places are dead bone cells. And you can see how this is spreading. Now this is the third molar area, so you can see how far back of that third molar this is spreading. Now the mandibular nerve is here, and you can see that there's a beginning breakdown of the sheath of the mandibular nerve. And if you look closely, you see dead bone cells surrounding it here and here and here. And some dentists are a little timid about wanting to go around and tease those dead bone cells away from around that mandibular nerve. But if you don't do it, it's going to keep growing, and pretty soon you're going to have this down here, and it'll eat up the mandibular nerve, and they'll end up without any nerve supply at all in that area. So it's imperative that we learn how to do these things and to get them done properly. You still think I'm an alarmist? This is I apologize for showing this slide because I know you can't read it. But for those of you who aren't acquainted with acupuncture meridians, there are at least probably a dozen different charts available about acupuncture meridians. And they all will have a row of upper teeth and a row of lower teeth. And off of it, there'll be these boxes showing where the meridian for that tooth goes to, what tissues in the body, in other words, it goes to. So you all want to have one of these, and every time you get a health history, you look and see which tooth are involved in those meridians, and you want to be particularly careful that that tooth doesn't have a periodontal pocket, or doesn't have a root canal, or isn't just a dead tooth that you're not seeing as a dead tooth, because it could be causing the problem. Now, one of the most simple ones to pick up is the eye tooth, which is the cuspid tooth here. And the root of the eye tooth is very close to the eye, and so that's where it got its name, eye tooth. And obviously, if you've got an eye problem and you look at that tooth and say, does it have a root canal? And if it does, you say to the patient, hey, you're not going to get rid of that eye trouble until you get rid of that tooth. And so you do that, and the eye trouble disappears. Now, the eye tooth's also on the gallbladder meridian. And so you get some people who come in and say, gee, I got gallbladder trouble, and they want to take out my gallbladder. And so the dentist looks at the eye tooth, and he sees whether the cuspid, and sees whether it's infected. And if it is, he says, let's remove it. And lo and behold, when he does, the gallbladder trouble disappears, and the patient doesn't have to have the surgery. Now, the biggest one of all to be concerned about is the third molar. Now, most people have had third molars removed, but even when they haven't, the third molar itself is usually a problem because it's crowded and there's infection in the gum. And so if the third molar is present, it usually has to be removed. But when it has been removed, 94% of them we find still have cavitation infections in the jawbone. Now, all 4 of mine were, all 4 of my wife's were, and you have to say, how come all 4 of them were when she only had 1 third molar? I don't know what the answer is, but I think the answer is that the tooth bud that originally was in there was defective, and it didn't produce a tooth, and that the body tried to get rid of it, but before it could get rid of it, bacteremia happened in the body, and that tissue picked up bacteria and set up an infection there. That's my explanation. I don't know whether that's true or not, but or whatever it is. At any rate, this third molar is on the heart meridian. And I can't tell you the people that call and tell me that after they've had the cavitations taken care of, that their arrhythmia disappeared, their heart disease problems that they have been told about or have been suffering and disappeared. And so you can bet you've prevented a lot of heart attacks, because one of the reasons for so many heart problems are the infections that appear in those third molar areas.
George?
Yes?
You think that's one of the reasons why we have so many heart problems in this country?
Absolutely. That's why I'm pointing it out. I think that's one of the big reasons. Now, there's a lot of good nutrition reasons and other things as well, but that's a particular reason. I won't have time to get into that. This was written, surprisingly, in 1982, 2 dentists and a PhD, and this woman had a brain abscess, and they reported to the neurologist that she had this badly infected tooth, and they thought it should be removed. And the neurologist said, "Oh, you guys are just tooth happy. You want to monkey around with teeth all of the time. Just forget it." Well, they couldn't do anything about it because they wouldn't let them take the tooth out, and the patient died in 2 weeks. And so none of them learned anything from that one. But we now know that there are so many brain problems going on, and with 30 to 40 million root canals being done every year, you can bet you that a lot of the mental upsets and a lot of the brain tumors and brain growths and so on are coming from teeth. And if you look at the fifth nerve and the trigeminal nerve, if you've got an infected tooth here, you're only 2 inches from the brain. And you can be a lot further than 2 inches from the brain and still get brain problems. But when it's that close, you've got to know that between the nerve and the blood vessel closeness to this, it's nothing to transfer those bacteria into the brain. And so why we should be surprised about this is alarming, and why most medical people don't pick it up quickly is also alarming. Now, most bone scans, a lot of people go and get bone scans, and most of them won't show cavitations at all. This is a technetium 99, and it will show them, but not when they're very small. It doesn't show them very well. But this one, this was a edentulous person, and the whole upper jaw you can see was cavitation, and the whole lower jaw. Except if you look closely, you see it's 3 places here, and those are joining together. There's that bone infection is increasing in size. It's getting together with itself and doing that.
George,
Yes.
can I just say something while you're on this?
Yes.
If you order a bone scan on a patient that comes back to be read by a neuroradiologist, he's going to look at that and say periodontal disease. That's what they're taught to diagnose these x-rays as, because everybody has some degree of periodontal disease. You have to look at these yourself. That's not periodontal disease. That's rampant cavitation disease.
Thank you very
And
much.
not all bone scans are going to be positive, even with a cavitation there, because a bone scan is predicated on some type of active metabolic process, whether it be dying bone or infectious bone. Cavitation, osteonecrosis, is dead bone, so you can have a full-blown cavitation and have a negative bone scan. And if you do a bone scan, you have to order the MDP. It's a monoamine diphosphate, I think, or something like that. That gives you a more technical readout and makes these more accurate. But don't rely on a bone scan to give you 100% accuracy as to the presence of osteomyelitis, osteonecrosis, or osteosclerosis, especially if it's heavily necrotic.
Thank you, Chris. You know, this is so great. And you know, there's going to be Sunday, there's going to be a round table, so you don't get much time for questions, or you can't catch us on the corner about this. Why, bring it up on Sunday at the meeting. More cures for cancer. Dr. Issels was mentioned in the introduction. I had the privilege of having him sit in front of me right here at cancer control meeting where I gave this lecture, and he and his wife. And I had heard about his work about 4 years ago. And let me tell you, his treatment of cancer was that the whole philosophy was that it's a total body disease, not just the breast or not just the liver or the kidneys or whatever it was. It was a total body thing. But the surprising thing is that he started this cancer hospital in Germany 40 years ago. He kept it for 30 years. And 10 years ago, he sold it and he moved to the United States. But 40 years ago, one of the first treatment they did was to remove root canal filled teeth, and secondly, removed amalgams for teeth. That is, he had the dental profession do that. But he knew that his percentage of success, which was one of the best in Europe, was due to getting rid of those sources of the problem. And one of the key things that he found was that the toxins coming from the bacteria were very closely related to the same chemical that the Germans used in World War I to make mustard gas. And that if that was present, it could be the cause of the cancer, but whether it was the cause or not, you were never going to get rid of it until you got rid of that source of that chemical. And you're going to find Mrs. Issel a charming woman to listen to. And this is Dr. Issels, and it's a shame we've lost him because he was a great man. I think you're all aware of that. The immune system is one of the most important factors of this whole thing, and it's the one that I have the most trouble with patients and to some extent with dentists. And this becomes difficult because you have to picture what is happening here, and that is we have these primary cells that are involved in the immune system. And when those bacteria are escaping from those dentin tubules into the periodontal membrane and then into the blood supply of the jaws, and from there floating around in the blood immediately starts picking up those bacteria by way of its white blood cells, its macrophages, its T cells, its lymphocytes, and they're working like mad to control this infection. Now people say, gee, I'm in good health, why should I have that tooth out? You know, I can tolerate that. And I used to think that may be, you know, suitable to do. But when you get to thinking about it, how long is it going to take before these cells wear out their ability to reproduce themselves day after day when you got this infection going on day after day? Aren't they going to break down and eventually give you a problem? Well, we now know that one of the key diseases that are being talked about in medicine is what's the name? I'm flipping. Immune deficiency disease. Well, of course, if you got deficiency of this, you're going to get all kinds of diseases developed that are immune deficiency. And so this is a real problem to solve, because it is so easy to say, well, I'm only 23, and I could have that tooth for a long period, and I have to say to the patient, you want to play Russian roulette with yourself? How long is it going to take before you develop one of these immune system diseases? And that could be heart trouble, liver trouble, kidney trouble, or a host of diseases. And Dr. Rosenau listed in the 1920s, listed 137 diseases that could be traceable to teeth, and we now know that's well over 200. And so you want to risk some of that stuff in order to put up with this. This is what a macrophage looks like if it's blown up 30,000 times. I don't know who did this, but I thought it was a pretty good picture, so I show it. I won't have time to talk about this, but Dr. Fisher, who wrote this, did a lot of research and reported all of the research up until 1940 that was done on root canals and to some extent on focal infections, and he listed numerous people who died because of dental problems. And that's why you get that title, Death in Dentistry. And when I was writing the root canal cover-up, my first title that I had selected for the book was Root Canals Can Kill You. And I finally decided that I better not do that. It was a little too strong. I would end up probably getting more criticism than I was going to get worthwhileness, and so we didn't use it. But I thoroughly believe that that's a problem. I understand you've written a book, and I guess you know that, and Carol and Ed Rana have some here, and the Price Pottinger Foundation has, and so on. That's what it looks like if you haven't seen it. I think most of you have seen it and distribute it to patients. You professional people, you waste an awful lot of time in your offices trying to tell people about focal infections. It's much easier to just say, hey, you got a real problem, you better have this book, and sell it to them. If you don't like selling books, why? What a lot of dentists and physicians do is to say, hey, get this now, and if you don't want it after you've read it, bring it back and I'll buy it back from you. And they all assure me that nobody ever returns one. I think they don't return them because they've loaned them to friends and relatives and they didn't get them back themselves. So there's 7 major causes of focal infection cover-up. And do I have time to?
You're running out of time, guy.
Okay.
You have a lot of slides. You want to go through them, or?
No, what I'll have to do, what's happened is that
Why don't you summarize what you got?
I'm in the process of doing another book, because in the original one, we covered about 3 or 4 or so of the causes of the cover-up. But over this period of 5 or 6 years now, we have learned some other very startling ones, and one you're going to learn from Hale Schachman today that changed the whole face of endodontics and everything else, because it solidified the fact that in the minds of the endodontists that the focal infection theory was not viable. And so all of the work has been based on a falsehood, and we're in a terrible position with all of that. So I want to write about what all those causes were, and I also want to write about the half a dozen things that have happened in the interim to show that the focal infection theory and what was discovered 70 years ago was accurate and true. And a lot of those you're hearing about today, and so this won't be a secret to you, but this is what I was going to be showing in here. And so I appreciate very much the time you've given me this morning, and being here with you has been a real thrill. Thank you very much for your attention.
Very good. Great slides. Beautiful.
I'll get out of here.
Any quick questions for George while he's here?
How do you feel about implants?
I'm sorry.
Yeah. How do you feel about implants, Mrs. Issel?
I didn't realize it was Mrs. Issel. Thank you. So I haven't had a chance to say hello to you. So we are advising, or at least I'm advising people to wait 5 or 10 years. With titanium, they have improved a great deal, but there is still an electrolysis problem between metals in the mouth. There is another big problem with implants, and that is that the average implant dentist is not aware of cavitations. He becomes aware of one when he sinks the hole for the metal root of the tooth that's going in there. If he happens to run into the hole, then he realizes that there was infection there. But he does not associate that with what we're talking about in focal infections. The problem is that a lot of those exist, but just very near where his implant is. And so eventually his implant fails because that infection will spread into the implant area, or because they have other infections develop and the patient begins to have pain in his jaws, or he's got systemic problems of various kinds and so on. So there's a lot of reasons for failures in those cases. At any rate, my comment to people is, hey, they're expensive, postpone them for a little while because you might be blowing your money anyway, for this.
Extracted bicuspid orbital, so you've got the teeth closing up.
I didn't catch.
Or bicuspid extraction.
Oh. I don't know whether Chris is probably better to answer that. I've seen that happen. I'll tell you in my own case, I had 2 deciduous molars removed at 8 or 9 years of age. No space maintenance made, and so I had 2 impacted bicuspids down here. And I had those out numbers of years ago. And we found that there was cavitations there. As a matter of fact, the last one we were going to do the 3rd molar, and before Chris got after it, I looking at the film and I say, Chris, look at that bicuspid area. It doesn't look right to me. And so he looked and he said, hey, how'd we miss that? So we went in and did that. The interesting thing about that is we assumed that the cavitation was due to the removal of that bicuspid. But there was no problem around that bicuspid when we removed it. And a couple of weeks later, I'm laying there in bed thinking about it, and it dawned on me the infection was probably from that deciduous tooth that was extracted when I was 9 years of age. And it's been there all those years. Now, we don't know. We're never going to know. But that's what I thought probably happened with that. Thank you very much.
Let's take a break. Let's convene at 11 o'clock sharp. That gives us about 25 minutes. Visit our distributors or exhibitors.
In it, nor can I imagine a situation where an attorney who has a proper understanding of the benefits of this would not want to go through the process either. But again, everyone has to agree that it is in the best interest of the process at hand. And if Chuck had said, I don't want to do this, he and Terry could have argued about that and worked that out, and we may not have been able to do it. But fortunately, it came about and we were able to go in and do this particular review. So again, it's voluntary and it requires the consent of you especially, and certainly that of your attorneys. What is the general criteria for a claim review? We generally look at claims that have $250,000 up on them, either a combined ratio of its loss and expense numbers. And if it's a climbing matter where that's increasing relatively rapidly, we'd like to really take a look at it. That's not to say we wouldn't be interested in looking at something on a lower limit if you brought it to our attention. Early earlier you can get, obviously spending $250,000 on expense or having that kind of money up on a file in anticipation of paying is one that probably needs to be taken, a look needs to be taken at it. But if you've got a situation that is going down a path that you feel might be out of control and you want to have a reality check, again, that's an opportunity for us to come in and take a look at it. And that may be at a lower threshold than $250,000. If your defense team and you disagree about some issues, then you might want to have us come in and take a look at it. And if the situation where our supervisors in the field have some questions about it and they would like to have an opportunity to have another set of eyes and ears, they would probably be suggesting it to you and waiting for your consent back. So again, that's how these can be brought to our attention. After you've had an opportunity to decide if it's a claim you want to have reviewed, again, you'd contact the claim supervisor who has the file for us. That person would in turn send that information on to us in Monterey. We would then forward it on to the appropriate individuals. Most likely for the time being, it will still continue to go through Bill Jabs, who is the chairman of the committee. Bill and I and others would probably evaluate who would be the best individuals to take a look at that. We have a limited group of people that are available to participate in that, and I'll get to that in a minute, but right now it's a very small group and it's not too difficult to try to reel someone in to help us out. We have 2 additional claims we're going to do the first week in December back in New York, and I am in the process of lining up individuals to help with those in the review of those 2 claims. Once we get the information into our office, it's distributed, it's reviewed, and that's the prerequisite work that needs to be done before we go out into the field. I think the advantage that in this particular claim we had great documentation from Al Rabaska, and it was clear, understandable, and it made sense. That gave us the foundation to go in, and then when Terry came in, there were other additional documentation that was prepared at his offices back in Baltimore, and then Charles came in and added some more to that package, and we ended up having a great deal of information available at a very quick time frame. There wasn't a lot of dead time in this process. It went very quickly. In fact, the entire day was over without, I think we even had lunch in their offices that day and didn't even realize that the day had passed so quickly. And yes, you too can become a reviewer. There is some criteria. We have a questionnaire that was prepared which has been photocopied and is out on the desk outside the doors adjacent to the stack of last year's documentation that Bill mentioned on the history of the program and where it's going to go. Feel free to take the questionnaire, and I would love to have you fill it out and submit it. And if you can get it back to either me directly or any of the DPIC people here, they will route it back to my office in Monterey, and we will take a look at it and evaluate it. It's fairly easy to fill out, ask some simple questions, and we can go forward from there. Essentially, what we're looking for are people that have had experience in this industry for 10 or 15 years, have had significant claims experience, not necessarily on the receiving end of that, but we do require that the individuals have gone through a claim within their own firm at one time or another. We call that seasoning, and a painful process as it may be, it does add to the mix. It makes it a lot easier for them to go into a situation and have stood in the shoes of the individual we're meeting with, and it takes a lot of the strain out of that potential accusatory type process that sometimes people feel will happen. This is far from that. It's much more collaborative and much more advisory in nature. We also pay for all expenses in the travel, and we do pay a $500 honorarium for the participation in the program. And with that, I'd again encourage you to pick up the information outside on the table and also take a look at the documentation prepared in last year's binder. If you don't have it or you weren't at last year's convocation, please pick that up and review that as well. Thank you, Bill.